Hello guys, a very good evening to all of you and I welcome all of you to today's session and today we'll be discussing the topic of CNS, Central Nervous System, and I hope you guys are following the schedule that I've given you. And see, week by week we have already reached almost to the half of pharma today, covering CNS, Central Nervous System, and then we're remaining with the other half of pharmacology. So let's begin with today's session, guys. So it's a premiere session. It's not a live session. So I'll be, in the chat box with you guys, and whatever queries you have, you can ask, and I'll answer in the chat box. So let's get away with today's session, guys. As you can see, central nervous system is what we're gonna discuss today, and to begin with the first question. Which of the following is a preferred anti-epileptic for migraine prophylaxis? So, for migraine prophylaxis, the drug of choice are beta blockers like propranolol is the drug of choice, but then I can also use anti-epileptics. Now, many of you or some of you at least would go for valproate, which is the wrong answer. Valproate can be used for migraine prophylaxis, but it is not a first line, it is a second line drug because of its side effects like obesity and alopecia, which are highly undesirable in a female, right? There is a reason why valproate is not preferred. Lamotrigine, carbamazepine, they are never used in migraine. So what I'm left with is topiramate. Topiramate, it is an important drug for migraine prophylaxis. First, we go for a beta blocker, and nowadays, if a female does not respond to beta blocker, the next drug we start is most of the times it is topiramate. So migraine is an important disorder, and anti-epileptic, which is used, they ask. So topiramate, as far as uses of topiramate is concerned, it is least about epilepsy. It is more about the non-epileptic uses. One of them is migraine prophylaxis. Apart from that, we can also use it for alcohol dependence. We can also use it in obesity. So these are the atypical uses which are more commonly asked about topiramate, right? Next, prophylactic vitamin K is given in pregnancy with warfarin, aspirin, valproate, phenytoin. Now, warfarin is not the answer because see, warfarin as it is, I should avoid in pregnancy. And if I'm using warfarin in pregnancy, then vitamin K has nothing to do with teratogenicity. Warfarin is teratogenic, but it has nothing to do with teratogenicity. Aspirin and valproate has nothing to do here. With valproate, we rather use folic acid because it can cause neural tube defect. So answer is phenytoin. And why answer is phenytoin? The reason being, see what phenytoin does, it is an enzyme inducer. And it being an enzyme inducer, it would induce metabolism of vitamin K, decrease vitamin K, and that can cause hemorrhagic disease in the newborn. Now, to prevent that hemorrhage in the newborn from happening in the third trimester in pregnancy, I give the female vitamin K so that the factors are restored even if the female is on phenytoin, right? So answer is phenytoin. It's a simple MCQ, guys. Now, coming to a clinical case, a patient suffered head trauma due to fall and after a few months presented with episode of partial seizure. He is suffering from depression, hypertension, liver cancer, kidney stones, and is taking many drugs for same. Which of the following anti-epileptic drug would be appropriate for partial seizure treatment in this patient, right? Now look at the options: carbamazepine, phenytoin, topiramate, gabapentin. Now, what do you think is a better answer here, guys? Think about it. What is the answer? I'll give you some time to answer. Comment. Think what is the answer and comment the answer. What is the answer, do you think? Carbamazepine, phenytoin, topiramate. Now, first of all, if I look at kidney stones, I can straight away rule out topiramate. Not to be given because it can itself cause renal stones, calcium stones because it blocks carbonic anhydrase. Carbamazepine, phenytoin, these are two options I'm left with, and gabapentin. Now, carbamazepine, phenytoin should not be given here. Why? The reason being, see, the patient is taking many drugs, and these two drugs, they are what? Enzyme inducers, and they would induce metabolism and can cause failure of many drugs. So I have to go through a lot of trouble for dose adjustment for all these drugs. Why do I need that when I have a better drug like gabapentin, which is not metabolized? It is excreted unchanged by the urine. So whenever drug interaction is a problem, I can use gabapentin. I can use gabapentin for that reason, and it is a case of partial seizure. And well, gabapentin is well effective in partial seizure, so there is no problem. So such type of MCQs, they are asked nowadays, and these are multi-layered MCQs. They will test knowledge of not a single drug but multiple drugs, right? Another case, guys, an 8-year-old boy was brought to the emergency with an episode of GTCS, generalized tonic-clonic seizure, and was managed accordingly. He is also suffering from absence seizure and currently is on ethosuximide, so which is the drug of choice for absence seizure currently. It is not valproate. What is the best course of action in this child for further management? Right, so look at the options and comment the answer. Option A, increase dose of ethosuximide. Option B, add clonazepam to ethosuximide. Option C, stop ethosuximide and start lamotrigine. Option D, stop ethosuximide and start valproate. Come on, guys, come on, comment. What is the answer? What is the answer? What do you think is the answer? You can take some time, think, ponder upon it because it's a case. And then comment, what is the answer? Is it A, is it B, is it C, or is it D? What do you think, guys? What is the answer here? Is it A, B, C, or D? Now, guys, see, ethosuximide, this guy has already developed an episode of GTCS as well. Ethosuximide is not effective in GTCS. Now, option A, increased dose of ethosuximide, it is not going to do anything for us by increasing the dose. It's not going to cover up for GTCS. Add clonazepam to ethosuximide, this is also not going to work because clonazepam, if I add it, it is more effective for seizures like myoclonic seizure, for seizure like the seizure which is caused by this one, what is called as infantile spasm. So in those, I can add clonazepam. Stop ethosuximide and start lamotrigine. Now, see, lamotrigine is not a first-line drug in absence seizure. Though lamotrigine, this option C, could be a correct option. But see, the MCQs are not about the correct option. They're about the best option, right? So lamotrigine is not the answer here because it is not a first-line drug in absence seizure. The better answer here is option D. Valproate is a first-line drug both in ethosuximide. Both in GTCS and absence seizure only if there is atypicality. Atypicality means if the seizure duration is more than 10 seconds or change in muscle tone. In this case, since the kid has developed GTCS, I'll choose valproate as a first-line drug in GTCS. It's very good to cover absence seizure. So option D is the right answer. Now, if you have answered option C, it is not a crime. It's not a crime because it's not a stupid answer. It might be a wrong answer, but it's not a stupid answer. But A and B, I'm sorry, right? All right, which of the following benzodiazepine has no active metabolite? Now see, these type of questions are more asked upon benzodiazepines. Benzodiazepines, all right, first of all, what is the answer? I'm pretty sure most of you will give the right answer here. Is it diazepam, lorazepam, clonazepam, midazolam? It's an easy one, guys. It has been asked. This particular topic, if not MCQ, then this particular topic has been asked many times. You cannot even count. So benzodiazepines, mostly the MCQs upon drugs related MCQs, short-acting benzodiazepines. So they do not have, these are metabolized only in phase 2. And that is the reason why they do not have no active metabolite. They do not have any active metabolite. These are safer in elderly and renal failure. So whenever they ask you, these are the points which they ask is an MCQ, and they ask you which is the benzodiazepines. These are short-acting benzodiazepines like lorazepam, temazepam, oxazepam, and astazolam. So, try understand, even if I don't remember any other benzodiazepine for the exam, it's not a crime. Keeping the competitive exams in mind, this is what they're interested in. This is what it has been asked. The most recent MCQ was alcohol dependence, and the patient develops seizure. Which drug would be used? I'll not use diazepam. I'll rather use lorazepam. So here, even the answer is lorazepam. Option B is the right answer, right? So you need to, so whenever you prepare for a competitive exam, you need to know your focus areas where the MCQs can be asked. So I should not spend, half an hour memorizing the long-acting benzodiazepines. I don't, but I need to have these drugs on my tips, which are short-acting benzodiazepines. All right, another MCQ. Which of the following is shortest acting benzodiazepine? Four options: A. Midazolam, B. Lorazepam, C. Clonazepam, D. Remimazolam. Now, guys, what do you think is the answer here? A, B, C, or D? What is the answer? Come on, guys, think. Come on. What is the answer? Comment the answer. Comment the answer. Now, whoever goes for the answer as midazolam, it will be a wrong answer. If you would have answered it 2 years back, it would have been the right answer, because then remimazolam was not approved. Currently, the shortest acting benzodiazepine is remimazolam because it is metabolized by plasma esterase. And this is something I've taught you. Any drug metabolized in plasma, it has to be very short acting. And in fact, these are the shortest acting drugs in their class, which are metabolized by plasma esterase. Remimazolam, it has a half-life of around 30 to 60 minutes, half an hour to 1 hour. So what is it approved for? It is approved for sedation or anxiolysis for short-term surgical procedures that will last for not more than 30 minutes, right? So lesser than 30 minutes. For that, I can use remimazolam. Now, mind you, remimazolam will be asked in the upcoming exams, right? All right, now a clinical case, right? It's a difficult one. A patient of OSA presented to the OPD with symptoms of intermittent awakening at night due to his own loud snoring, because of which his work is suffering due to daytime sleepiness and headache. He was prescribed temazepam for insomnia. This prescription is A, rational, because temazepam will treat insomnia and improve symptoms of OSA. Rational, because temazepam will treat insomnia but has no effect on OSA. C, irrational, because temazepam will worsen OSA. D, irrational, because temazepam is not effective in insomnia caused by OSA. Take some time. I'll give you some time to ponder upon the answer. It's a clinical case, and obviously you'll need some time, right, to weigh your options, to go for which one is the answer. Take your time. It's okay. It's fine. I'm not going anywhere. I'll give you an adequate time to answer this. So, guys, what is it? Is it A? Is it B? Is it C? Or is it D? Now, see, in your exams, you'll get one-liners which you need to answer as soon as possible within 5 seconds, easier ones. Such MCQs, so that you have more time from those questions which you can reutilize in these MCQs, which are longer ones, right? Now, here, the answer is, guys, is obviously irrational. The reason being, and the reason is temazepam worsens OSA. Why? See, what happens is temazepam or benzodiazepines, they relax the pharyngeal muscles, and because of which they will increase the symptoms like loud snoring and worsen OSA. So benzodiazepines, they're never used for OSA per se. And second is benzodiazepines, they can also cause respiratory depression. There's another thing that can worsen OSA, because in OSA we are trying to stimulate by giving drugs like carbonic anhydrase inhibitors. We are giving CPAP, right? But I'll not use a drug which causes respiratory depression. So C is the right answer. Now, in your exams, right, if you don't get the right answer for such questions, it's pardonable. It's okay. These are not ranked deciding MCQs, but you cannot, not even this one. You cannot do such MCQs wrong. These type of MCQs, ऐसे MCQs जो हैं, आप इनमें गलती नहीं कर सकते. You cannot. You are out of the competition, right? All right. A patient was referred to neurology OPD with symptoms of asymmetric limb weakness, muscle atrophy, spasticity, and fasciculations. So obviously it is a case of ALS, and he was started on edaravone and baclofen. This drug baclofen in patients significantly relieved spasticity by opening which channels? I've taught you this. I've included this MCQ because I've taught you this in the lectures. How does baclofen produces muscle relaxation? Option A, which channels? Which ion channels? Option A, chloride. Option B, potassium. Option C, calcium. Option D, sodium. So guys, come on. What do you think is the right answer here? A, B, C, or D? Which is the right answer here? Come on, guys. Come on, come on, come on, come on. Chloride, potassium, calcium, sodium. Which is the right answer? All right, your clue is baclofen is a stimulator or agonist of GABA B receptor, which happens to be a GI subtype of GPCR. It happens to be a GI subtype of GPCR. And this GI subtype, it opens potassium channels. It opens potassium channels and in your spinal cord, and that is the reason why there is MR or muscle relaxation. So here answer is potassium. Answer is potassium. So this is nothing, something I'm asking out of the blue. I've discussed this in your lectures, right? So answer is potassium, guys. A patient of multiple myeloma having severe bone pain was prescribed drug for analgesia, which is sequestered in tissues and hence gives a well-controlled 24 hours analgesic effect. This drug that was given to the patient is, so basically it is a description of an opioid that I've given you guys here. And I want you to pick the right opioid here. Is it A, morphine, B, pethidine, C, methadone, D, buprenorphine? What do you think is the right answer? A, morphine, B, pethidine, C, methadone, D, buprenorphine. So A, B, C, or D. Now guys, I've discussed this. Answer, comment the answer. Come on, comment the answer before I tell you the answer. What is the answer? It's an easy one, guys. I'm pretty sure 90% of you will give the right answer. It can be even 100%. Right? So methadone. Methadone is a drug which is sequestered in tissues. And that is the reason why I can say it has a high volume of distribution. I can say because it is sequestered, it is long acting. Because it is sequestered, it does not precipitate withdrawal symptoms. And the most important use of methadone is where? In opioid dependence, for what? To decrease withdrawal symptoms, right? So that is what you need to understand. Buprenorphine is not the right answer. Buprenorphine has, what they ask you here, it has high affinity for mu receptor. Buprenorphine has high affinity for mu receptor, so even it produces a longer duration of action because of high affinity for mu receptor. Suicidal tendency can be precipitated by suvorexant, zolpidem, ramelteon, flurazepam. A, B, C, D. Right, suicidal tendency can be precipitated by suvorexant, zolpidem, ramelteon, and flurazepam. What is the answer, guys? Clue is this is an MCQ on a new drug. And so I've virtually given away the answer to you guys. Now at least can you comment what is the answer? This is a side effect of a new drug. So answer is suvorexant. So what is suvorexant, guys? It is a DORA. It is a DORA, dual orexin receptor antagonist. So they block the effect. They block the effect of orexins. Right? They block the effect of orexins. And why God has given us orexin? Orexins, they are usually required in the daytime to maintain wakefulness. So we are awake during the daytime, plus they have anti-stress effect. They relieve stress. So when I block this, I'll feel sleepy. Plus that anti-stress effect is gone. So if a patient is of depression or has suicidal tendency, it can be precipitated by drugs like suvorexant. And the latest one is here, daridorexant. Right. Latest one here is daridorexant. And suvorexant, daridorexant. This is the current drug of choice for, remember, sleep maintenance. It has changed, guys. I've covered it, updated in the Marrow edition 6, sleep maintenance. Whereas the current drug of choice for sleep induction or jet lag is ramelteon. If there is no response, then I can go for zolpidem. I'll be using zolpidem if there is no response. Now, this is a slight change in treatment of insomnia that you have to understand. Opioid with alpha-2 receptor agonism, tapentadol, pethidine, tramadol, both B and C are correct. Come on, what is the answer? A, B, C, or D? Come on, guys, comment. What is the answer? Right, because There is an option D which says both B and C are correct. You might get a little bit confused, but it's okay. Take your time. All of you who are watching this video must answer. Don't wait for me to tell the answer. You commit. You have to commit to an option. Give the answer. Only then you're going to learn, right? So commit yourself to an option A, B, C, or D. So guys, here option D is the right answer. The reason being pethidine, tramadol, both these, they are alpha 2 agonists. And this is the mechanism of action behind these drugs being used in post-operative chills. So, pethidine and tramadol, these are two opioids which are used in post-operative chills. And if they ask you what is the mechanism, why do we use them? It is because of alpha 2 agonism. Apart from this, some MCQs they have asked regarding tramadol. Tramadol, it increases norepinephrine and serotonin by inhibiting reuptake. This also contributes to analgesic effect. Tapentadol, it is almost like tramadol, but it inhibits reuptake of norepinephrine, right? So these are the MCQs which they have asked. This has been asked. This can be asked. This can be asked in your upcoming exams. Now, moving on to the next question. Naloxone cannot reverse the effect of which drug? Morphine, methadone, pethidine, buprenorphine. 4 options. Take your time. Just the right answer and comment it. You can take some time. Just think which is the possible right answer here. A, B, C, or D, guys. What do you think? Morphine, methadone, pethidine, or buprenorphine? Which is the right answer here? Morphine, methadone, pethidine, or buprenorphine? Which is the right answer? Guys, here the answer is buprenorphine. I told you something. Buprenorphine, it has high affinity for mu. And this is the reason why. Because of this high affinity for mu, it is contraindicated in labor analgesia. Why it is contraindicated in labor analgesia? Because see, you know that if I use this drug in labor analgesia, I give it to a mother, it might cross the placenta, and the baby, when it is born, the baby might develop respiratory depression. And for that respiratory depression, if the baby develops, I'm supposed to use a drug called as naloxone. Naloxone would be able to reverse the effect with these drugs. But if I've given buprenorphine, your naloxone is not gonna produce any effect. It is not gonna reverse respiratory depression. Buprenorphine, not. The reason being, it has high affinity, it has more affinity than naloxone, and naloxone cannot displace this. The baby will die of respiratory depression. So that is the reason. This is something they can ask you in your exams. Right, so option D, buprenorphine is the right answer. Which of the following is an MSSA antidepressant? It's a new question. It's a new question. Might be asked because they have asked you regarding something called as, which is a NASA antidepressant. This has been asked. And your answer is mirtazapine, which is a NASA noradrenergic specific serotonergic antidepressant. I've asked an MCQ which is quite similar. All right, you might not know the answer. It's okay. Make a guess. Make a wild guess. Make a wild guess which is the answer. You see, obviously, mirtazapine is not the answer because I've given you the point. It is a NASA, not a massa, right? So, is it vilazodone, vortioxetine, or bupropion? Which is the right answer here? Guys, here, see, what does it mean? It means multiple. See, it is not MSSA, it is MSAA. Multiple serotonin agonist antagonist. So MSAA, multiple serotonin agonist antagonist antidepressant. Yeah, the answer is vortioxetine, guys. Vortioxetine is an SSRI plus it is a partial agonist at 5-HT1A. It is antagonist at 5-HT1B, 1D, 5-HT3, 5-HT7. There's a reason why It is called as MSAA, multiple serotonin agonist antagonist. Vilazodone is an SSRI and partial agonist at 5-HT1A. So remember, vilazodone and vortioxetine, these are novel antidepressants. Both are used for resistant depression, major depression. A recent MCQ that asked you, which of the following is a novel antidepressant? Your answer was vilazodone. So vilazodone, vortioxetine, these are novel antidepressants. Mechanism, I've told you what they can ask in your exams. Right, so your option C is the right answer. Erectile dysfunction is seen with A. Mirtazapine, B. Bupropion, C. Amitriptyline, D. Vilazodone. Guys, what is the answer here? Erectile dysfunction can be seen with which drug? Mirtazapine, bupropion, amitriptyline, vilazodone. What do you think? What do you think is the right answer? Come on. See, erectile dysfunction. Why do you see erectile dysfunction? Is because of primarily increased serotonin. I've discussed this in the lecture. We stimulates 5-HT2 receptors in the spinal cord, and that causes erectile dysfunction, which means what? Any drug that can increase serotonin can cause erectile dysfunction. It can be MAO inhibitor, it can be tricyclic antidepressant, it can be SNRI, it can be SSRI. All of them, they can cause erectile dysfunction. Simple logic. Whatever is remaining does not cause erectile dysfunction, right? So here you can see mirtazapine will not cause erectile dysfunction, bupropion will not cause, vilazodone will not cause. Here your answer is amitriptyline. The reason being, amitriptyline is a tricyclic antidepressant. Vilazodone, because I said it's a SSRI, but it has 5-HT1A partial agonism. So because of that reason, somehow vilazodone does not cause erectile dysfunction, right? So remember which drugs they cause erectile dysfunction by increasing serotonin. Everything else that is remaining, it falls under drugs not causing erectile dysfunction, right? All right, coming to a clinical case, a 23-year-old man is going around the colony asking everyone for money for his new startup, which is named as Udi Baba. He is confident that by next year he'll beat Elon Musk to take everyone from his colony to Mars and have a settlement there. He was brought to emergency by his parents that he has not been sleeping for the past 1 week and keeps drawing rockets on paper. Which of the following pair of drugs should be started in the patient? All right, haloperidol diazepam, lithium diazepam, lithium risperidone, clozapine, imipramine. Guys, what do you think? What is the answer here? What do you think is a better answer here? A, B, C, or D? First of all, what is this case? What is this patient having? This Udi Baba patient is having what? And this is a case of acute mania. So basically, I'm asking how to treat acute mania. You know, in acute mania, we treat acute mania by combining an atypical antipsychotic is our drug of choice, and we combine an atypical antipsychotic with lithium. So here, the better answer here is lithium and risperidone. Lithium and risperidone. And remember, acute mania, I'm never going to use imipramine-like drugs. Antidepressants. Remember, antidepressants can cause mania because mania is opposite of depression, right? Another case, guys, a patient presented to emergency with dyspnea, choking feeling with palpitation. She felt as if she will go crazy soon. On history taking, she shared that she had similar episodes in the past as well, but this time it was unbearable as she thought she's going to die. One of her relatives advised her to take escitalopram, which she took for similar condition, and she has been taking it for past 1 week. Escitalopram could have aggravated her situation because of 5-HT2 receptor upregulation, 5-HT2 receptor downregulation, 5-HT2 receptor stimulation, 5-HT2 receptor block. Come on, guys. What is the answer here? What is the answer? So we gave SSRI to a female, only SSRI, and the patient has developed anxiety, and that is because of what? See, normally in a synapse, Whenever I give SSRI, it increases serotonin, and this serotonin stimulates 5-HT2 receptor, and this is what is responsible for anxiety, which will be seen for 2 to 6 weeks. Why? Because after 2 to 6 weeks, what happens is these receptors, they begin to migrate inside, and after 2 to 6 weeks, what happens is called as 5-HT2 down regulation, and when they are down regulated, this will produce anxiolysis. So remember, if they ask you anxiety caused by SSRI is because of what, then your answer would be 5-HT2 receptor stimulation. If they'll produce, it is used in anxiety disorders, or how does it produces anxiolysis, then your answer would be 5-HT2 down regulation. So that is the reason why here B is not the answer. Because of this anxiety, at least for 1 month, I prescribe the patient with benzodiazepine. That is what has gone wrong here in this case. The patient has imitated someone just by the hearsay. He started taking an SSRI. It can be suicidal, guys. Right? The anxiety can hit through the roof. Right? So SSRI should not be given alone. Never without the cover fire of a benzodiazepine. Right? False about lithium. So which is false about lithium? Low therapeutic index. It is true or false? It's true. Earliest sign of lithium toxicity is diarrhea. Is it true or false? It is true. Dialysis is contraindicated in toxicity. It is done. It is false. Toxicity is seen if plasma concentration is more than 1.5. It is true. So dialysis is done. Dialysis is done when it is more than 4.0 milli equivalents per liter. Lithium is a very important drug in central nervous system, entire central nervous system. The single most important drug is lithium. It has a probability of 99% of being asked in any exam. There is only 1% chance it might not be asked. The examiner is not in the mood to ask about lithium, right? So here, C is the right answer. So lithium, guys, lithium, you have to revise before the exam. A 62-year-old female was brought to the OPD with symptoms of forgetfulness for past 1 year. She has an MMSE score of 22. She was diagnosed Alzheimer's disease, started on a drug that acts on beta amyloid. The drug being described here is donepezil, memantine, aducanumab, edaravone. What is the answer, guys? Donepezil, memantine, aducanumab, edaravone. It's an easy one. It's the latest MCQ. MCQ has not been asked, but it will be asked. Aducanumab. Now remember, donepezil, it can be used in mild, moderate, severe Alzheimer's. It is drug of choice. Memantine, it is used in moderate to severe one as add-on. So, see, mild Alzheimer's, I can use only donepezil, it is fine. Moderate to severe, I can use only donepezil. If the patient does not respond, I'll add on memantine, which is NMDA antagonist. Aducanumab, it is anti-beta amyloid mab, which is used in mild disease only. Only mild disease, plus there must be confirmed presence of beta amyloid plaques in the cortex. So here, your answer is aducanumab, guys. A patient of psychosis is on haloperidol for last 2 years and is well maintained. However, for the last few days, he has developed repetitive involuntary movement of hands, facial grimacing, and lip smacking. The patient has developed these symptoms due to D2 receptor block, D2 receptor stimulation, D2 receptor upregulation, D2 receptor downregulation. Right. So what is the answer here? The patient has developed these symptoms due to D2 receptor block, D2 receptor stimulation, D2 receptor upregulation, D2 receptor downregulation. First of all, make a diagnosis. What is this? See, involuntary movement of the limbs and the face, tongue, protrusion of tongue. This is tardive dyskinesia. So basically, I'm asking, what is the mechanism of tardive dyskinesia? See, why tardive dyskinesia is seen? See, tardive dyskinesia is seen. See, this is D2 receptor and you're blocked for many months or years. So whenever you block this, there is dopamine here. It's not able to bind to D2 receptors. So whenever you block a receptor for a very long period of time, what happens is called as receptor upregulation. So there is a huge amount of D2 receptor, and this dopamine, by binding to D2 receptor, will produce dyskinesia, that is called as tardive dyskinesia, abnormal movement of the limbs and the facial muscles and tongue. So here, what is the answer, guys? Come on, what is the answer? The answer is D2 receptor upregulation is the answer in tardive dyskinesia, right? A patient of Parkinson's disease is on levodopa for last 7 years. For last 1 month, he develops coriform movement of the body 1 hour after taking the drug. Which of the following drug can be added to levodopa to relieve the patient? Tetrabenazine, valbenazine, pramipexole, amantadine. Right, first of all, what is the problem? Levodopa 7 years. Coriform movements of the body 1 hour after taking the drug. Which of the following drug can be added to levodopa to relieve the patient? So what is this coriform movement of the limbs? It is also dyskinesia, but it is levodopa-induced dyskinesia. That was tardive dyskinesia, and it is due to excess of dopamine. So dyskinesia can be due to excess of dopamine or excess of D2 receptor. Tardive dyskinesia is because of excess of D2 receptor. Levodopa-induced dyskinesia is because of excess of dopamine. So levodopa-induced dyskinesia, what is the drug of choice? Now comment the answer, guys. Come on. At least tell me now what is the answer, A, B, C, or D. Here, D is the right answer, guys. The drug of choice for levodopa-induced dyskinesia, it is amantadine, right? So now, guys, you can ask your doubts and whatever doubts you have, because it's not a live session, so I cannot cover the doubts. But as it is, I have been answering your doubts. I'll be answering the doubts in the comment box as well. And whatever doubts you have, I've already told you whatever doubts you have, you can always message me in Instagram. My Insta handle is docpharmaniac. And if you have some doubts, that is even after the live session, you can always message me. I'm just a message away, and I try to answer all the doubts within 24 hours. I try my best, guys. I try my best. So, guys, thanks a lot for participating in today's session, and I'll post the topics for next week. That is antimicrobial drugs, antibiotics. I'll post it today, and then you can gradually cover it up, and gradually you'll see, guys. You'll see that week by week, day by day, hour by hour, will gradually cover up pharma in such a beautiful way that it would immensely increase retention, right? So guys, take care. All the best. Bye-bye. This was Dr. Ranjan with you.